Thank you for that introduction. It's very impressive for me to speak before many people who've trained me, people for whom I have the highest esteem, and many colleagues. I wanted to focus my talk on listening to patients' families. The first message is that families are not mere visitors in the ICU. They know the patients, they defend their interests, their values. Families are suffering, and above all, they offer us an acceptable model of the patient-physician relationship. They represent the patient and allow us to avoid many mistakes and severe impacts on our own health. So the literature is unanimous. Families are really at the front of the scene. They represent the patients, but they want to express how much they're suffering. The patient is small here. The patients, the family are in the forefront. We must listen to them, understand how they see things, how they articulate things, and the quality research work with semi-directive interviews, using theories and software packages to restore systems for palliative care to understand what's important from the viewpoint of the family. So analyzing these words from a qualitative analysis to highlight what's important, what is redundant, what returns, and allow us to better understand what's important and that we must move towards in order to improve interaction, communication with families. So why listening? Because listening is also caring. Very often information is speaking to be understood. Having spoken, having checked that we're understood, we have to listen, because it's at those times, as I'll demonstrate, that we can improve patient and family outreach. And of course, nurses and physicians are one united team. We have the same values. We're not synchronous. We have different backgrounds, and we move in a different way towards the same different decisions, but we do come together in terms of emotions. We must recent concepts, conflicts, complementarity, disagreements enrich a decision-making process, and the time that each person takes to reach a decision is safety in the decision-making process. Let me just return to the fact that families are not mere visitors to the ICU. The way in which you express this, obviously we don't say to people they're not visitors. We start by saying hello. We take a minute to say good morning. I'm the nurse, the physician, the intensivist. The patient's just been admitted. It'll take a while. There are other patients. We might not see you today. And if the physician can just put his head around the door and say, probably pneumonia, we're going to administer antibiotics with a ventilator, people don't go back and log on Google. And so this hello is very important in the minds of the family. We saw Dr. So-and-so, he's very busy, we'll see him again tomorrow. So take the contact details of the families means that they're important in order to supplement the information that's required for the patients, but also to give them a place, like the interview on day 3, that extended visiting hours 24/7 is not perhaps the ideal solution. We've moved from 2 hours to 8 hours on average in France, and we distinguish between the visiting time that's very extended in a third of ICUs 24/7 and the happy hours that are moments for information, and we distinguish between visit and information. And we've also learned to understand through what families tell us what the role that they wish to play in the decision-making process. We've learned to reassure them even when the patient will in all probability die. We can find the words to reassure, to communicate, to assist, and to evaluate. Recognize the families in the patient's interest, meets their needs and expectations. Extended visiting hours gives them recognition. There's a debate on what place in the families in the ICU. I'll return to that later. So why are families so vulnerable? It's because they're afraid. All these data come from interviews, families that we've spoken to. We try and understand how we could improve and better meet their needs. They're afraid for the patient. They're afraid that he's going to die, to lose him, that maybe lose a very small chance of survival in therapeutic overkill. Obviously, they're afraid of taking decisions. Most don't want to take decisions. They don't always feel respected. Sometimes when we don't give them enough time, when we avoid looking at them, or when we laugh in ICU, we have to explain. They have financial problems when visiting hours are very limited. You have to take time off for work. The cafeterias in hospitals are quite expensive. There are conflicts. Families had conflicts before ICU. They can heighten in ICU, and our information doesn't always meet their needs. And in the interviews, there's really something that we find often is, I want to know if something's going to happen. Will I be called? Will I be warned? I don't want any bad surprises. In the 10-12 articles on visiting policy, this one has the advantage of following a good methodology but offering areas for improvement. In the Maïté Garouste paper at Saint-Joseph, we see that we must allow nurses time to organize their care. That's not incompatible with extended visiting hours. Physician must perform a good quality clinical examination. It's not incompatible, and families are more stressed when there are extended visiting hours. They feel compelled to stay and to spend less time with their children. It's very important to have a communication strategy that removes guilt. Come when you like. We have to remain all the time, but you don't have to visit all the time. In an ICU, there's nothing to hide. The extended visiting hours start from the principle that it gives a degree of flexibility. Most of the studies have shown that families came less when they could visit as they please. And in an ICU, you can have your own room. This is a rather specific case, but within certain safety limits for the patients, you can come as a family and continue to live normally while the patient's in ICU. The day 3 meeting is a milestone, a meeting that's recommended because it provides families with a point to interact on day 3 or on day 5, few days after admission into ICU. We sit down with the families in a meeting that's not at the initiative of the family but of the nursing medical team. Tomorrow at 2 p.m. can you come, so that we can review the situation. It's pluridisciplinary, at least the physicians, nurses, and other people too, and an opportunity to repeat, to reformulate, tell us what information you've received. If there's any misunderstanding, we can clear that up, and also understand the balance in the family, who the patient was, his preferences, his values, and how he interacted with the person before us. And it's a study before and after. In this study, we saw that after this systematic meeting on day 3, well, obviously there were far fewer conflicts. There were more days during which families and the carers were in sync in looking after the patient. And one small thing during this meeting on day 3, the patient's in the serious condition, but we must present the patient as if he's going to improve. A coma, meningitis, that the patient wakes up, who's breathing alone, fewer machines. In this image, we don't have to give the other image. To give the image of the patient who's waking up, the family's grown up, and if the image is not there, then of course his condition's worsening. The second part of listening is to reduce the hardship of the experience. To listen means to relieve. There's something that's pervasive in the interviews with families. They're at the forefront, but we, the carers, are a figure of authority, and they need us to see them suffer, and there are many symptoms that the patient has. The family will complain. It needs to seek us out. Observation information, the fact that they are recognized as suffering, and we must support them and recognize those emotions, saying that it's important that we respect them for that. And families very often in those times, whilst we're listening to them, they want our approval to know whether they're taking the right course in terms of understanding and quality of the information they've received. And if this is really this process that's based on trust and confidence, recognized by the largest team in the world that's just received a huge grant from the U.S. government to improve palliative care. Andy Curtis in Seattle, and in a very simple study with 51 interviews with families recorded, we see that the more the family speaks out, the greater its immediate satisfaction is, the more it felt listened to, the less there's conflict, and it'll make its grieving easier. But satisfaction will be very low if we haven't allowed family space for discussion so that we can listen to them. Second thing, families will send out SOSs. They're putting questions. I should have come the day before yesterday to ICU. He wouldn't be in that situation. I should have done this, that. We should have called. And those are lifelines to be seized and to remove guilt from family. They come in various forms. We see there are questions. In a third of cases, we don't answer those questions because we haven't listened. Clarifications, the families will misunderstand. We won't restore the right information, or missed opportunities for compassion. Or feeling guilt-ridden. We should have said that, of course, had you come yesterday, he would have returned home, or it was a very sudden disease, you wouldn't have been able to do anything. It's taking the time to listen, to complete the information, listen, respond, is really not to overstate things, but the decision for this is only based on certainty, on a form of consensus-based certainties, that the chances of a cure or of having sequelae incompatible with normal family life, and don't leave the patient isolated, don't abandon them, patients and family, don't treat them like an object, respect their values, give them time, leave place to the family in decision, whatever it is. To refuse to take part in a decision-making process, the family will understand that we're not going to base the decision on their shoulders. Treat the symptoms to really promise the family that the patient won't suffer, no distress, won't be hungry or thirsty, the small things that are key to palliative care that we must promise to deliver to the family in the end of life. This is the family conference based on trust, where each item comes from a study. It's fairly compelling because all these items are not too empirical. They stem from a study, shows that it has yielded and improved the well-being for family. Randy Curtis called it in an anagram, value, appreciate what the family says, to acknowledge the family member's emotions, to listen, you to ask questions that would allow the caregiver to understand who the patient was as a person, and above all, at the end, the E, to elicit questions from family members. And to answer those questions, in a randomized trial in the Famille Réa 8, we compared a COM strategy based on value that was active listening with the normal management of families to whom we're going to announce an imminent death. And for many, this was a randomized trial, rather characteristic as all RCTs, a strategy. We listen, or we don't take account of what the family says, allow it no time. The families for whom we took time to listen to, well, first of all, more families, because it's proactive. We asked families to organized to come. Many, the nurses were there, and meetings lasted 10 minutes more, during which the families could express their viewpoints because they had more time to speak. Ditto for the nurses. It was 3 minutes. I hope that's risen to 8, and overall families had time to express their emotions, and that was key. 90 days after death, this intervention made it possible to significantly reduce symptoms of anxiety and depression, and also post-traumatic stress disorder related systems after death. Craig Lilly was probably right to say that it was all about the healing power of listening in the ICU. I don't know if now this is part of reality, but we probably take a bit more time in listening families from managing the early end-of-life process to demonstrate and show that they are important. This active listening is difficult for us because obviously we're worried about speaking to be understood, and of course our words we're going to try and learn, but our words have far less impact than the tone, our non-verbal communications, our hands, our posture, our reaction, and the impact of those items far more important than the words. Nevertheless, our control of the non-verbal and the tone of voice goes in the opposite direction, and we must take account of that in the various training sessions. Active listening is to be careful to have a family that's connected, that sometimes we have to allow a few seconds of silence so that the families take the initiative to speak. A lot of interaction, try and steer the family where you want to take them, to direct them. Active listening, answer questions, and seize the opportunities offered. Listening to families is also responding to their needs. Our way of communicating, is it right? A nurse in the 80s, on the basis of interviews conducted, had defined family needs that have become criteria for responding, measuring satisfaction in the critical care family needs inventory, of rating the more important questions in a rigorous manner. When we look at family satisfaction, they love the information provided by interns. A few days after ICUs, the junior doctors must be part of the process, of course, with the nurses and the physicians. The junior doctors condone no contradictions. Family want to know to whom they're speaking, whether there's a leading carer, and also if we have time. But look at these items. None of them mention the patient. The families are in the forefront. To a certain extent, they'd almost wish for some of them be in the decision-making driving seat, but many can't. Will return to this emotional paradox, this imbalance, very painful for them. So these family needs, we tried to assess them in a piece of research work, quite in-depth, of meetings with nurses and physicians during 1 week in several wards. They noted all the questions put by family. We're able to collate over 2,000 questions with qualitative semantic analysis measures with a template reduced to 21 questions. And Laurent Papazian is directing a randomized study, Famille 17, which is a randomized trial where these questions are offered or not to families to see whether it allows family to put questions and if it allows carers to answer those questions. Listen to family is to know whether our interventions are effective. Here in a randomized trial at the end of the 90s, we did a trial to test how effective a basic leaflet was to receive families in ICU. We see that it improved comprehension and also improved satisfaction. These parameters allow comprehension, satisfaction, and that the juniors, the seniors will provide information that's perceived in the same manner by families, really opening an important scope to families and to juniors to take part in the information and to interact with families in ICU. So these criteria, listening to family, is to understand when there's a family that's grieving or about to grieve in ICU, to understand reactions in the face of death, emotional distress, depression, anxiety, anger, hostility, but also cognitive reactions, suicidal thoughts, concentration, memory disorders, 25% during grieving processes stop work, and also behavioral, but also endocrine, immunological, and we were very impressed by this paper, which shows that of mortality after the hospitalization of a spouse, there's a 5% increased death for a spouse, and up 21% when a spouse deceases. We are dealing with people who are vulnerable standpoint, including from the physiological, somatic standpoint, very few suicides, but also financial difficulties and the slide into depression. Another paper shows when one of the members of one of the spouses die, the other tends to die shortly afterwards. These are quality papers, not just with depressive disorders, as in DSM-4, generalized anxiety disorder. 45% of families one day have many of these disorders, depression, complicated grief disorder. We're dealing with vulnerable families. In this study where we mentioned the post-traumatic stress symptoms through a self-questionnaire completed over the phone or a bit more by the families, that 1/3 of the families, in fact all families after ICU, whether the patient has survived or is deceased, had PTSD 90 days after. In grieving families, it's more, and this heightened PTSD is, of course, grief. But we did see that families that were involved in a decision-making process, actively involved, had 80% of PTSD symptoms, and this is remorse for taking part in a decision-making process. We always have the impression of taking the wrong decision, or this idea that the patient has lost a very small chance of survival, and we must work in ICU, and also it's the others to work after ICU in order to remove the guilt felt by these families. In a recent study by Nancy Kentish, we see that in addition to PTSD, there's complicated or extended grieving, and that these situations of complicated grieving, there's an interference with PTSD, but in fact there are also people who only have one complicated grieving process, 15% of cases, and PTSD. And we know that the risk factors of one or the other for some different, which currently offers new targets for improving information and communication for managing these grieving families. And for the last part of my talk, I'd just like to answer the question, what involvement of families in decision-making process, by discussing these data that have been confirmed showing that the presence of family during resuscitation of extra-hospital cardiopulmonary condition, that the emergency workers have really come to terms with that. And above that, the families, when they're questioned 90 days, and this was confirmed up to a year after patient death, when they're present and they've seen that the nursing team did everything to save their relative, the grieving process is less complicated, less anxiety, less PTSD, and they consume fewer psychotropic drugs. Involvement of family in the decision-making process, obviously it's possible to adapt this contextuality in the face of two very identical situations, patients of the same age in the same situation or end of life. We can allow the family full place in the decision-making process or none whatsoever. 15% of ICU patients have no relatives coming to see them when they're in the ICU, and a lot of family presence. That's when end-of-life situation, when family members will come to recall what the patient's needs are. Ditto in Canada, 15% in both groups, where the physician has to decide because there's no family input. And you see that the family in Canada, as in France, rarely decides. It's shared decision, shared model. If the family wishes, allow the family to provide input, but it has to have the means through well understood information, through meetings that meet their needs, and above all, respect for their will not to decide. A family that doesn't wish to provide input needs to be informed regularly at its request, at our request, but we can't force people to take those decisions. In the US, we see in Canada and France the same. If we dissect decision-making process and define 10 criteria for shared decision with the families. In these interviews, only 2%, that is, one decision in 51 met the 10 criteria, and there's a whole trend in the US to respect the non-participation of families in the decision-making process, and to others allow them to do so by sending out messages such as respect the patient's wishes and recall what his preferences are. In the shared decision-making model, we can be very convinced by Terry Fried, Pittsburgh, Maite Gahutz at Saint Joseph. The best thing is to ask the future ICU patient. We have to go at risk, immunodepressed patients, very elderly patients, and show them videos as Maite did and ask them what their wishes are. Okay, so I was also very convinced by a model, an adaptive contextual model. Here on the y-axis, the fact that we're capable of predicting outcomes, difficult to predict the outcomes at the top, and along the x-axis, quality of life on the left will retrieve quality of life on the right, lose all autonomy. When a patient, it's very easy to know that he will recover everything. Very simple, factual information, generally over a short space of time, sustained, that will suffice. But when it's very easy to understand that the patient's going to die or that there will be serious consequences to the point of limitation, at that point in ICU, introduce palliative care, respect the preferences and wishes. It's in those situations that the families must be in the driving seat by recalling that they don't want extensive treatment, and generally we're in sync with them. The difficulties in the middle, we don't know if the patient's going to recover, we don't know what the after effects will be. That's what we must communicate with the families and have adaptive communication strategies. This model is probably the most adaptive. This decision-making paradox, of course, families want to take decisions, and families at the same time don't want us to engage in overkill, obviously places them in a very ambivalent, ambiguous situation, and we have to juggle between their wishes to take the decisions because they feel empowered by the patient. We must remove all guilt, communicate, interact, tell them what we're doing. It will help them hugely. And of course, they place their trust in us if they want to become vulnerable. There's a pendulum effect that must be managed to ensure that this ambiguity, ambivalence of families doesn't impact on their emotions, because that leads to guilt. There's no two ways about it. To empower the families to take decisions when they wish to, and we feel they can. There are cognitive aspects. We have to acknowledge families that have difficult systems, acknowledge families that haven't understood. There are emotional items. In end of life, the nursing staff, the physicians are suffering. We have to be able to manage, talk, interact, have shared moments, also respect the patient's values, to go home without taking that back with us. On the one hand, we have to learn to communicate. On the other hand, we must organize, anticipate meetings with families, end-of-life meetings, and open our wards, not 24/7, but as much as possible. Just to close, in terms of communication of end of life, we need a sort of a standard of care. We know that families, 16 minutes of information per day, and generally speaking in practice between 0 and 100 minutes. We must reach that level. We have the culture, I know I'm good. We have to recognize the need to learn. Recommendations on information by SRLF, one of the first learned societies which back in 2001 had drew up guidelines. We must update them. When there's a conflict with family, we must have a clinical approach. We must, of course, eliminate all the differential diagnoses, as we do with our patients. Have we done something silly? Is there contradiction? isn't this family suffering, and that's why it's coming towards us. We have to be rigorous, systematic, and this approach solves many conflicts, perhaps 95% of those conflicts we've assessed, we've evaluated. We must learn the lessons, recognize that families are partners in care as others. It'll be either harmony or catastrophe. Understand that there are benchmarking items between wards, satisfaction, end-of-life quality, and symptoms after ICU. In conclusions, we're not ethicists. We are a pluridisciplinary group assessing practices in terms of information and communication. We've taken successive snapshots that represent the efforts undertaken to do better. Of course, we could have considered from the outset that our results were known beforehand, that obviously stating the obvious, as Frédéric Pochard says, but we would have been far less convinced, we would have learned less and had less fun. Of course, families have changing needs. We have to assess them, update them regularly. The ideal model of the physician-patient relationship is a concept. In practice, things change because we have the ability to adapt. The pluridisciplinary approach has advantages, brings all this quality research, allowing the families to better understand, to give meaning to what we observe. Here again, it has disbenefits to be in the concept and in theory, but this qualitative research has become vital, and this research is really research. I'd like to thank by acknowledging those supporters of Famirea and all the centers, including all these patients. Thanks very much. Thank you for that introduction. It's very impressive for me to speak before many people who've trained me, people for whom I have the highest esteem, and many colleagues. I wanted to focus my talk on listening to patients' families. The first message is that families are not mere visitors in the ICU. They know the patients, they defend their interests, their values. Families are suffering, and above all, they offer an acceptable model of the patient-physician relationship. They represent the patient and allow us to avoid many mistakes and severe impacts on our own health. So the literature is unanimous. Families are really at the front of the scene. They represent the patients, but they want to express how much they're suffering. The patient is small here. The patients, the family are in the forefront. We must listen to them, understand how they see things, how they articulate things, and the quality research work with semi-directive interviews, using theories and software packages to restore systems for palliative care, to understand what's important from the viewpoint of the family. So analyzing these words from a qualitative analysis to highlight what's important, what is redundant, what returns, and allow us to better understand what's important and that we must move towards in order to improve interaction, communication with families. So why listening? Because listening is also caring. Very often information is speaking to be understood. Having spoken, having checked that we're understood, we have to listen, because it's at those times, as I'll demonstrate, that we can improve patient and family outreach. And of course, nurses and physicians are one united team. We have the same values. We're not synchronous. We have different backgrounds, and we move in a different way towards the same different decisions, but we do come together in terms of emotions. We must recent concepts, conflicts, complementarity, disagreements enrich a decision-making process, and the time that each person takes to reach a decision is safety in the decision-making process.